This is part 2 of the schizophrenia lecture. Let's talk about positive symptoms. Delusions are greater than 75% of schizophrenics have that. False fixed beliefs that cannot be corrected by reasoning, and you should not confront delusions. After trust is built, you can help them examine the evidence so they can determine if it's reality. Control is believing that another person, group of people, or external force controls thoughts, feelings, impulses, or behavior. An example is Brian covered his apartment walls with aluminum foil to block governmental efforts to control his thoughts. Then there's ideas of reference. They are giving personal significance to unrelated or trivial events, perceiving events as relating to you when they are not. Example is Barbara believes that the birds sing just for her when she walks down the street. Persecution is believing that one is being singled out for harm by others. This belief often takes the form of a plot by people in power. An example is Peter believed that the Secret Service was planning to kill him by poisoning his food. Therefore, he would eat only prepackaged food. Grandeur is believing that one is a very powerful or important person. Example is Sam believed he was a famous playwright and tennis pro. Somatic delusions are believing that the body is changing in unusual ways, like rotting from the inside out. An example is David said his heart had stopped and was rotting away. Erotomatic is believing that another person desires you romantically. An example is although he barely knew her, Patty insisted that Eric would marry her if only his current wife would stop interfering. And then jealousy is believing that one's mate is unfaithful. An example is Sally wrongly accused her spouse of going out with other women. Her proof was that he came home from work late twice, even though his boss told her that everyone had worked late. Concrete thinking is impaired ability to think abstractly. An example is if you state, "The glass is half full," the patient would be thinking you were talking about an actual beverage. And then with speech, there's a few different things like clang association is when words are based on their sound rather than meaning, often rhyming or having a similar beginning sound. Examples are on the track, have a Big Mac, or click, clack, clutch, close. There's also word salad. We discussed that earlier. Neologisms are made-up words that have meaning for the patient, but a different or non-existent meaning to others. And echolalia is the pathological repeating of another's words and is often seen in catatonia. The nurse may say, "Mary, come get your medication," and the patient will say, "Mary, come get your medication." Alright, some others. Religiosity is an excessive preoccupation with religious themes. Magical thinking is believing one's thoughts or actions can affect others. This is common in children, like wearing pajamas inside out to make it snow. Paranoia is an irrational fear of others. Persons who fear others may sometimes act defensively, causing harm to others, so they are at risk to them. So just keep that in mind. Circumstantiality is unnecessary and often tedious details in one's conversation, describing their breakfast when asked about their day. Tangentiality is going off on tangents in a way that takes the conversation off topic. Cognitive retardation is slowing in the pace of thinking, represented by delays in responding to questions or difficulty finishing one's thoughts. Alogia, or poverty of speech, is a reduction in spontaneity or volume of speech. And then there's rapid or pressured speech. There's flight of ideas. It's moving rapidly from one thought to the next, making it difficult for others to follow the conversation. Thought blocking is a reduction in the amount of thinking or an abrupt stoppage of thought that derails the conversation. Thought insertion is when one's thoughts are not one's own or that they were inserted into one's mind. Thought deletion is a belief that one's thoughts have been taken or are missing. Illogical, disorganized, or bizarre thinking can be a symptom, positive symptom, and inability to maintain attention, so they're easily distracted and have off-topic comments. Another positive symptom is depersonalization. It's a feeling that one is somehow different or unreal or has lost his identity. People may feel that body parts do not belong to them or may sense that their body has drastically changed, like a patient may see her fingers as being smaller, more distant, or not her own. And derealization is a false perception that the environment has changed, like everything seems bigger or smaller, or familiar surroundings seem somehow strange and unfamiliar. And hallucinations are perceiving a sensory experience for which no external stimulus exists. Hallucinations differ from illusions in that illusions are misperceptions or misinterpretations of a real experience. For example, a man sees a coat on a shadowy coat rack and believes it is a bear. He sees something real but misinterprets what it is. Types of hallucinations include auditory, which is usually hearing voices and it's most often experienced by schizophrenic patients, can be supportive or frightening for the patient. The patient may attempt to drown out with loud music or by talking loudly. And command hallucinations will direct the person to take an action, and we must assess the patient safely for themselves and others. There's also visual hallucination. It's when they see persons or things that are not there. Tactile is feeling bodily sensation that are not present. Olfactory is smelling odors that are not present. And gustatory is experiencing tastes that are not present. Some positive symptoms with bizarre behaviors include inappropriate clothing, appearance, and social or sexual behavior, inappropriate aggression or agitation, and continued repetitive of certain motor patterns like twirling their hair. Catatonia is a pronounced increase or decrease in the rate and amount of movement. The most common form is stuporous behavior. Motor retardation is a pronounced slowing of movement. Motor agitation is excited behavior like running or pacing rapidly. It's often in response to internal or external stimuli. It can pose a risk to the patient due to exhaustion, collapse, and even death, or to others like being knocked down. Stereotyped behaviors are repeated motor behaviors that do not serve a logical purpose. Waxy flexibility is the extended maintenance of posture, usually seen in catatonia. For example, the nurse raises the patient's arm, and the patient continues to hold this position in a statue-like manner. Echopraxia is the mimicking of movements of another. It's also seen in catatonia. Negativism is when the patient does the opposite of what he or she is told to do, which is active negativism, or fails to do what is requested, which is passive negativism. Impaired impulse control is a reduced ability to resist one's impulses. Examples include interrupting in group or throwing unwanted food on the floor. Gesturing or posturing is assuming unusual and illogical positions or expressions that are most often grimacing. And boundary impairment is an impaired ability to sense where one's body or influence ends and another's begins. This is a good chart delineating the differences between delusions, hallucinations, and illusions. It's important for you to know the differences. So then now let's talk about some negative symptoms. They develop slowly and are those that most interfere with a person's judgment and ability to cope. Negative symptoms impede one's ability to initiate and maintain conversations and relationships, obtain and maintain employment, make decisions and follow through on plans, and maintain adequate hygiene and grooming. Negative symptoms contribute to poor social functioning and social withdrawal. Affect is outward expression of a person's internal emotional state. Affect may not always coincide with their inner emotions. Flat affect is immobile or blank facial expression. Blunted affect is reduced or minimal emotional response. Inappropriate affect is incongruent with the actual emotional state or situation, like when a man laughs while a peer threatens him. And bizarre affect is odd, illogical, grossly inappropriate, or unfounded. It includes grimacing and giggling. Other negative symptoms of schizophrenia include affective blunting, which is a reduction in the expression range and intensity of affect. Anergia, which is lack of energy. Anhedonia is the inability to experience pleasure. Avolition is reduced motivation and spontaneous activity. Poverty of content of speech is when speech conveys little information because of vagueness or superficiality, even though there's an adequate amount of it. Poverty of speech is reduced spontaneity and amount of speech. They rarely initiate speech and respond in brief or one-word answers. And thought blocking is a sudden interruption in the thought process, usually due to internal stimuli. An example is a patient abruptly stops talking in the middle of a sentence and remains silent. And the nurse may say, "What just happened now?" The patient says, "I forgot what I was saying. Something took my thoughts away." So you need to assess for depression in these patients. They may be showing an impending relapse, increased substance abuse, increases in suicide risk, or further impairments in functioning. So if you haven't already watched the video with 4 patients who have schizophrenia, push pause now and watch it. Alright, some assessment guidelines. You have to assess for medical problems, assess for things that might mimic psychosis like brain trauma, delirium, fever, or UTIs. Command hallucinations. If they're present, be sure to ask, do you recognize the voice? Do you believe the voices are real? Do you plan to follow the command? And a yes to any of these questions suggests an increased risk that the patient will actually act on the command. Delusions, if present, you have to find out, are the delusions firmly held? Is the patient able to complete reality testing? Does the patient believe that he or loved ones are being threatened or in danger? Does the patient feel the need to act against a person or organization to protect or avenge himself or others? A positive response to either of these questions suggests an increased risk of danger to others. And self-safety. Does the patient have adequate food and fluid intake, good hygiene and self-care, the ability to move about safely, or have there been falls or walking into traffic, intact impulse control and judgment, and safe dress for weather conditions? These are a few of the nursing diagnoses that you will see. And the next 2 pages include nursing interventions that you can provide, and I'm not going to go through them. You can certainly read through them on your own. Alright, so psychobiological interventions. Antipsychotic medications have 3 generations, first, second, and third. Medication treatment is not a cure for the disorder. Most medications block dopamine receptors and some block serotonin reuptake. Goal of medications is to help the patient to be more involved in therapy and able to do their ADLs. There are many side effects, and we'll discuss those in some future slides. The problem with a lot of these medications is they don't become effective for 3 to 6 weeks. Alright, so view the short videos posted in Blackboard that show the side effects of akathisia, tardive dyskinesia, acute dystonia, and Parkinsonian. You can push pause now and go watch those. So let's talk about first generation and antipsychotics. 2 different types. There's chlorpromazine, or thorazine is the other name for it. It's low potency. And there's haloperidol, or Haldol is the other name, and it's high potency. There may be some early extrapyramidal side effects. We call those EPS. One is dystonia, where the muscle spasms of the face, head, neck, and back. Pseudo-Parkinsonism is tremors, reduced accessory movements, impaired gait, and stiffening of muscles. And akathisia is rhythmic movements, usually the lower limbs, and constant pacing. Some late EPS include anticholinergic effects like dry mouth, blurred vision, photosensitivity, urinary hesitancy, constipation, and tachycardia. Tardive dyskinesia, like involuntary muscle spasms involving the tongue, fingers, toes, neck, trunk, or pelvis. Usually starts with the tongue and progresses to the rest of the body. Lip smacking movements, in and out tongue protrusion. This can interfere with chewing, swallowing, and speaking. No treatment exists for tardive dyskinesia. It's irreversible. You just need to discontinue the antipsychotic and complete the abnormal involuntary movement scale, or the AIMS, AIMS. Late EPS also include weight gain, can be up to 100 pounds actually, include sexual dysfunction like impotence, and endocrine disturbances like galactorrhea, amenorrhea, or gynecomastia. Treating EPS, lower the dosage can minimize EPS, and add anti-Parkinsonian drugs may help with some of the side effects. Trihexyphenidyl, or Artane, is one of them. Benztolpine mesylate, or Cogentin. Diphenhydramine hydrochloride, or Benadryl. And amantadine, or hydrochloride, or Symetra. Second generation antipsychotics include acenapine or Safras, clozapine or Clozaril, and that you need to monitor for agranulocytosis, ioperidine or Fanapt, lurasidone or Latuda, olanzapine or Zyprexa, paliperidone or Ivega, quintiapine or Seroquel, risperidone or Risperdal, and ziprasidone or Geodin. Disadvantages: they can cause metabolic syndrome, which is weight gain, dyslipidemia, and altered glucose metabolism or insulin resistance. Can also increase the risk for diabetes, hypertension, and atherosclerotic heart disease. Third generation antipsychotic medications are unlikely to cause significant metabolic effects. They have little anticholinergic effect and do not seem to cause dysrhythmias. These are potentially dangerous responses to antipsychotics. Anticholinergic toxicity causes from blocking too much acetylcholine. Symptoms include hyperthermia, hot, dry, red skin, reduced bowel sounds, paralytic ileus, agitation, delirium, fluctuating vital signs, tachycardia, marked mydriasis, which is dilation of the pupil that stays dilated even when the light shines on it, confusion, mental status changes, worsening psychotic symptoms, and even coma. Another is neuroleptic malignant syndrome. This is rare, but it's life-threatening medical emergency. It's more common with first generation, but can also occur with second generation. The cause is from blocking excessive dopamine receptors. Symptoms include reduced consciousness, increased muscle tone, autonomic dysfunction like hyperpyrexia, labile hypertension, tachycardia, tachypnea, diaphoresis, and drooling. Treatment for this with early detection is to discontinue the medication, manage their fluid balance, rapid temperature reduction, and monitoring for DVT and rhabdomyolysis. And then lastly is agranulocytosis from clozapine. Monitoring for total WBC count below 3,000 or neutropenia, and for signs of infection or increased susceptibility to infection. They're going to have weekly WBC counts times 6 months, then a frequent intervals while on the clozapine. The stabilization phase of schizophrenia focuses on long-term care treatment and support for the patient. It includes medications, nursing interventions, and community support. All interventions are geared to the patient's strengths and cultural preferences. Milieu therapy will manage their environment and decrease stress and stimuli. These are some community resources that you should be aware of, and there are probably others in an area where you may be at. So residential crisis centers are for patients who cannot stay in the community but do not qualify for inpatient services. Halfway houses allow living in the community with a group of patients and sharing responsibilities. Day treatment programs allow them to reside in the community and attend structured programming. Mental health centers provide medication services, day treatments, psychotherapy, psychoeducation, and case management. Home health services provide in-home medication and treatment services. Employment programs provide services to help them succeed in the work environment. Peer-led services are drop-in centers that offer social contact, constructive activities, and sometimes employment assistance. And respite care is help for caregivers. So that's the end of our lecture. If you haven't already watched the video with Heather, go and do that now.